And this is by Mike McNitt-Gray from the University of California, Los Angeles, UCLA. Teaching cases 1, collimation versus slice width, coronal quality, dose, and scan time.
Good morning. That was an excellent couple of presentations to follow from Jim and Jim. Anyway, it's also my distinct pleasure to be here and to be asked to participate in this. So what I'm going to do in the next couple minutes is follow up on some of the points that Jim has made, and I'm going to hit some of the same things. So my apologies for redundancies, but these are things that we both felt were very important. In fact, I stole this slide from him because I wanted to start with talking about collimation and describe how it affects. He already talked about how it affects total scan time, noise, and the thinnest available reconstructed images that are available, and some of the same points. I'm going to elaborate on this just a little bit and give a case example. Right? Oh, talking about the thinnest available recons. Okay. So when we had done this dose summit about 8 or 10 years ago, we'd been talking about 4 and 8 and maybe even 16 slice scanners. And when we talk about collimation versus slice width or image width, we would have had to face significant constraints in terms of what the scanner was able to give us, right? In terms of what thickness could be reconstructed from a given configuration. With 64 slice scanners, many of those constraints go away, but they're not gone completely. So I'm going to walk through an example of this from our institution. We have a Sensation 16 from Siemens, and the configurations for helical scans are two basic configurations, 16 by 0.75 and 16 by 1.5. So this may go to some of the previous questioners' questions. This was a 12 millimeter nominal beam width. That's in 16 by 0.75. Okay? What you can reconstruct are all of these, potentially. Okay? 0.75, 1, 1.5, etc., all the way up to 10. Those are all available to be reconstructed from the same original raw data. Okay? However, with those 12 millimeter beam, you don't have quite as much coverage. You have 12 millimeter nominal beam width. In the 16 by 1.5, the beam width is doubled, okay, up to 24, but it allows a lot of the same slice thicknesses, 2, 3, 4. Note that even though this was a 16 by 1.5, there's no 1.5 millimeter reconstructed slice thickness. It was 2. Okay, that's the minimum. Okay, so look, we've done a little bit of trade-off here. Greater coverage, but we don't have as thin as slices. I think we already knew that, but I wanted to point this out and make it very explicit. Now let's keep going and work this out into how this plays out practically. If we were doing a Sensation 64 configurations for helical scans, and I'm going to talk a little bit about this later this afternoon, about some of these terms, you would see if you were sitting at the scanner, a 64 by 0.6, that's really a Z-flying focal spot. The actual detector configuration is 32 by 0.6, so the nominal beam width is 19.2, okay? And it allows reconstructions of 0.6, 0.75, lots of thin slices, all the way up to 10. Again, thinner slices, but less coverage. The other configuration available on that scanner is 24 by 1.2. Okay, so that's a 28.8 millimeter nominal beam width compared to 19.2, so a little bit bigger. But it doesn't allow a 0.6 or a 0.75. It starts at 1.2 and goes up to 10. Okay, so even with the 64 slice scanners, we have this little bit of trade-off between thin slices and coverage. Okay. All right. So the significance of that is what Jim mentioned before. I get to say Jim, and I don't have to be specific about which Jim I was referring to earlier. Some Jim mentioned earlier that you have to choose the collimation that allows the desired thickness to be reconstructed. If you need thin slices, then you have to choose the collimation setting that allowed those required thick slices, the required slice thicknesses. And as Jim Kofler was pointed out a few minutes ago, the thinner collimation settings are almost always, there are some exceptions, they are rare, but they're almost always a little less dose efficient. And as you go to really, really narrow collimations, they can be much less dose efficient. Okay? But the CTDI vol on the scanner will reflect that, as far as I know. All the examples that I've seen, so the CTDI reflects that. So that will have some impact on a couple things, right? One is the total scan time. Is that important? Do you worry about the scan time? Yeah, okay, we'll go through an example of that in a second. That depends on the body part, the study, the scanner. What about things with breath hold or timing with contrast? These are examples of where you worry about the scan time length. Okay, here's one example. I do a lot of work with my institution in the thoracic group. You really want to get through those acquisitions in a single breath hold, right? So Jim was using an example of 15 seconds. You really want to do that so there's no respiratory motion. 10 to 15 seconds max. It depends on the disease and the severity of the disease and the patient's capabilities. But you really want to keep that down. And you need to get approximately 300 millimeters of coverage, okay? Some are less, but I'm just throwing these out as ballpark numbers. Okay, so let's walk through an example. I'm sorry to go into so much detail, but I really wanted to drive this point home. Let's go through these two different modes, okay, back into sensation 16 and show what the trade-offs are in terms of acquisition time. In 16 by 0.75 mode with 12 millimeter beam width, if you use the pitch 1 and 0.5 second, the table feed is 12 millimeters per rotation. Table speed at a pitch of 1 is 12 millimeters per rotation divided by 0.5 seconds per rotation is 24 millimeters per second. So to get through an average 300 millimeter thorax, it takes about 12.5 seconds. Good. You're good. Your goal was 15. If you needed to go a little less because the patient couldn't hold their breath for 15 seconds, then you could always increase the pitch a little bit. Okay? If you compare that with 16 by 1.5 millimeter mode, okay, remember the trade-off. A little thicker slices, you're only going to be able to get as thin as 2 millimeters, but your coverage is going to be twice. So that scan time, rather than 12.5, is going to be a little less than 7 seconds, right? So if the patient really only can hold their breath for 10 seconds at a time, or if you're doing multiple breath holds or whatever, you may consider going to a little thicker, wider beam width, okay? But that's the price you're willing to pay, to go to 2 millimeters. I'm sorry if that's down on the bottom of the slide. Okay, so that's an example of the trade-offs you face with these different collimations. Okay, and if you hear anything today, I hope we hear that this is part of the dialogue that the physicist has with the radiologist and with the technologist. What's the requirements of the study? What do we need to see here? What do we need to do? What are some of the constraints in terms of time? Do we need thin slices? You're just going to look at axial reconstructions. In abdomens, for the most part at our institution, we do look at coronals and sagittals, but the axial images, 5 millimeters in adults, 5 millimeters. Do you need the thin slices? Only if you're going to do the coronals or sagittals or reformats. Okay? How about a high-res chest CT for diffuse lung disease? It's typically done in one of two ways. Sparse sampling, where people do axial scans 1 millimeter thick every 10 or 20 millimeters. So it's a sparse sampling through the lung. It's diffuse lung disease, so it's not something specific and small that you're looking for. A lot of people are doing this. We do this now too. We increase our sampling. We do a full chest helical CT, and we get 1 millimeter thick reconstruction spaced every 1 millimeter. Okay? For helical, we need those thin sections, so we choose a collimation that allows the 1 millimeter thick. Okay? I have some examples, a couple examples of that in just a minute. What about abdomen pelvis? Or in some places, I understand we don't do it this way, but some places are doing chest, abdomen, pelvis all in a single acquisition. Okay? Wow. Okay, that's a lot of coverage, right? Abdomen, pelvis, about 500 to 600 millimeters. 800 to 900, I'm guessing, in a chest, abdomen, pelvis. That's a lot. Can you do all that in a single breath hold? Okay. If possible, certainly as you get to the top of the abdomen or if you're in the chest. What if you're running contrast? Timing is important there as well. Okay, so here's some of the constraints that we're working with. How can we get through these given the configurations? Okay, if we're doing an abdomen, pelvis, or a chest abdomen pelvis in a sensation 16, let's go back to that one. 16 by 0.75, remember that's our less coverage but thinner slice mode. So if we were doing pitch 1 and 0.5 seconds, there's our 12 millimeters of per rotation coverage, 24 millimeters per second. And so that 500 millimeter coverage takes 21 plus a little bit more seconds. Okay? If we increase the pitch to 1.5, we can get that done in a single breath hold. Okay? And still get thin slices. 800 millimeter of coverage, no, we're not going to get that. That's going to be 30 plus seconds. And even if we do pitch of 1.5, we're still going to be in 23 seconds. But we'll get the thin slices if we need them. And 23 seconds if we go through the chest first, abdomen. By the time we get down to the pelvis, maybe you can have the patient relax. Depends on what you need. They can exhale. You'd prefer not, but that's some of the constraints, right? What would the alternative be? The alternative would be on this scanner to go to 16 by 1.5, twice the coverage. So for pitch 1 and 0.5 seconds, we go 24 millimeters per rotation, 48 millimeters per second. That abdomen pelvis 500 millimeter coverage would take about 10 seconds, pretty good. Okay? And if you really wanted to be aggressive and the patient was really breath hold compromised, then you increase your pitch to 1.5 and you can get 7 to 8 seconds. Okay? I haven't talked about the MAS constraints at all, but it's still in play here. I'm just talking about time. If you wanted to do chest, abdomen, pelvis, 800 millimeter coverage, 17 seconds when you did pitch 1, you could get it under 15 seconds if you went to pitch 1.5. Okay? But again, you've given up the 1 millimeters. You've gotten the 2 is the thinnest you can get. Okay? So I hope you appreciate some of these things. These are complex things that are interacting between time, collimation, and the options in terms of reconstructing slice thickness that you have available. Okay? I think I just mentioned that. The impact on scan time, the thinnest slice in that 16 by 1.5 mode is 2 millimeters. And the question is that going to be okay? How will the images be viewed? Do you need those coronal reformats? And if you're only doing 5 millimeter thick slices, then maybe that's okay. Okay. What about the choice of MAS level? What about will the thin slices be used? And if so, what MAS level can you choose to provide a low enough noise? Will you only be using thick slices? Again, these are questions that we have to ask about the exam. And as addressed by Jim Kofler, the thicker slices, more photons. Thicker slices give you thicker images, give you more photons and less noise. And I'll give you some examples of that in just a second. Oh, in fact, here it is. I don't know. Can we get the lights down even more? Maybe you can see this. I'm going to show you this a couple different ways. Here's an example of abdomen. This is similar to what Jim was showing in the fact that I reconstructed this data set with 5, 3s, and 1s. And this is a non-contrast abdomen. And I didn't have a good example of a thin little hypodense lesion, but I was also looking for regions where I might want to see some signal, and the radiologist might be interested in seeing what's happening right in different parts of the liver here. Okay, so I hope you'll pick out a region and compare and contrast that. And again, these are all from the same acquisition. Okay, here's one level, here's a different level in the same patient. This is a little bit of a big patient. It's not our biggest, but it's a little bit big. And here we are a little bit further down in the liver. Okay, and I hope you can really appreciate the difference that if nothing else, the confidence that the radiologist is going to have determining whether there is something unusual in that liver when we go to these really thin slices, when we're just looking at them cross-sectionally. Okay, how about down in the kidney? I saw this little hypodense region here. I had a little trouble finding it here, and I was really lost when I went to the really thin slices. Okay, again, a non-contrast abdomen. Contrast would help. Okay, but you can see, I just wanted to illustrate the effects of the slice thickness here. Okay, now we're going to look at it a slightly different way. Now I'm going to show them not next to each other, but one at a time, right? So here comes the 5. So pick an area, just like Jim asked you to. Pick an area that you were looking at. I was looking right around here. And I'm going to change it to the 3, and now to the 1. Okay? You appreciate that difference? Okay, here's another level. Here I am looking at the kidney, looking at that slightly hypodense region there. And this is the 5, the 3. And again, like Jim pointed out, it's a little sharper boundaries. Here we go from the 5 again, back to the 3. Notice the sharpness. Okay? And to the 1. Okay? So we've also hit that noise increase just by reducing the thickness of the image. Okay. Here's a couple other examples I'm going to finish with. This was a pediatric patient, and I wanted to show you some better examples, but this was a pretty good one. This was a pediatric patient suspected of having diffuse lung disease, which is there. We, unfortunately, went a little too aggressive in taking our dose down. Okay? And so we reduced the MAS, we had thin slices, and the radiologists really were not comfortable with some of the noise that was thrown in there with determining the presence or how much the extent of the diffuse lung disease was. So we actually overdid it a little bit in terms of our attempt to be aggressive, especially with this pediatric patient. One other point that Jim made that I wanted to bring home as well was reconstruction kernel. This was from a study that we did several years back where this is on an adult, and this was a lung nodule. And I think I wanted to use this to illustrate a couple things. In the abdomen and the diffuse lung disease, we were looking at subtle effects. Here's one that's not so subtle. So this is from our lung cancer screening trial, the National Lung Screening Trial. We did this at our what we called our conventional technique, which was down around 25 effective MES. And then we simulated, this is the original, this is about 25 effective MES. And I think these were 2.5 millimeter thick slices. And here we simulated a lower dose acquisition, and we did this with two different reconstruction kernels, okay? A B30 and a B50. And those of you not familiar with Siemens, this is a little bit smoother, a little bit sharper, and I think you can appreciate that in the depiction of the anatomy in this image. Here's the lesion. You can see it's a little sharper there, and that's probably your best look at it. That's the higher dose and the sharpest kernel. And here. Now, if you're looking for the lesion, any of these would be adequate, right? You can find it. If you're looking to characterize it or see if there's progression from the previous scan, this might be a little tougher with some of these looks. Lower dose, a little smoother, okay? Or if, heaven forbid, somebody had done this acquisition the first time and reconstructed it this way the second time, right? So you want to keep it consistent, especially when you're trying to do comparisons. But my point here was, in certain applications, you can go way down in the techniques, right? We're going to hear more about that later today. Okay. I think one of the last examples, this is sort of an artificial one, but I thought it would do a pretty good job of showing you what happens when you do thick versus thin, and then you reformat to a coronal. This was a little device. It's a one-way valve that we were doing a clinical trial on. It's just embedded in some sheets there, so there's no anatomy here at all. And I reconstructed this at 1.5 millimeter thickness. Okay, so there's the cross-sectional images, and you can appreciate little metal things about it. You can see some fingers in the valve and all that kind of stuff. Okay, and here I did some 10 millimeter thick slices. Okay, and then what I did was reformat it into coronals. Okay, so that you can see here's with the thins, so you can see that valve action in the middle of the device. Okay, there's the coronal and the sagittal, and then so this is with relatively thin slices, 1.5, and then again this is a totally artificial example. But I'm going to show you what it looks like with 10. Okay? Okay. So with those thicker slices, and then we use that as reformats, we've lost almost all of our ability to resolve any subtleties in terms of, this again, it's a valve, but you can appreciate what this is going to look like when we look at anatomy. And I'm going to show you one example in just a second. Oh, good. Here it is. Here's from again, a patient from our National Lung Screening Trial. We took these 2 millimeter thick slices and did a coronal reformat, and then we reconstructed them with 0.6. Same acquisition. We did not scan the patient twice. Just took the same raw data, reconstructed it twice. I hesitate to call this thick. When we saw 2 millimeter thick images the first time, we were ecstatic at the kind of anatomy we could depict. Then we saw these and we're just kind of blown away. Okay? But this is in the lung, right, where we have this great natural contrast between the vascular structures, the normal parenchyma, and the background. But even between the ones on the left and the ones on the right, if you were in the optometrist's office and he was saying, which would you prefer, A and B, I think you better be saying this one, right? So the anatomy is much sharper over here. Here it is at one level, here it is at a different level, and you can see, even as exquisite the depiction of anatomy here, it's really even sharper here. If you look in the abdomen, you can see the consequences of what we've done there as well. We're not looking in the abdomen, but if you were, here's what happened. We gave up that nice, even small separation in tissues there, and we've just obliterated it with noise. Okay? So there's a classic example of the slice thickness versus noise, and it shows up even in the coronal reformats. Okay. I think this is near the end for me. The collimation and reconstructed image thickness, it affects the total scan time as we walk through a couple examples. It affects the thinnest available recons that are available to you, depending on the collimation setting that you choose. Ultimately, the reconstruction of the image is going to affect your noise, low contrast resolution, and the quality of the coronals and other reformats. The implications of dose, I'm going to echo what Jim, I can't remember, maybe both of them said. If thin slices are used, the temptation is to increase the MAS to compensate and to reduce the noise. Okay? When they're using thin slices, they may look at the image and say, that's too noisy, and may try to compensate by increasing the MAS. It's a real temptation. Are the thin slices needed for the exam? Are they needed for diagnosis, for reformats? What are they needed for? Okay, not just pretty pictures. And is a proper reconstruction filter being used? Jim gave a better illustration of that, but I wanted to make sure we hammered that point home as well. And I think I'll stop there. Thank you.
Wow, we have some time for questions. We have about 7 minutes or so. Tony?
Mike, that was terrific. I'd like to ask a philosophical question of both you and at least one of the mics, maybe both.
One of the gyms.
Sorry, one of the gyms. Sorry, whoever.
Yeah.
If you need thin slices, then obviously it's something very subtle. So why don't you need to increase the MAS or slow down the pitch or do whatever you need to do to give you better signal quality, better signal noise? On the other hand, if it isn't necessary, then why not knock down the dose on the thicker slices so that you get poorer signal noise there too?
Tony, I think that's exactly right. I didn't make that point maybe as clear as I could have, but I think that's exactly right. And I think this goes back to, this is as a medical physicist, I can expound on exactly those principles when I sit with my radiologist and with my techs. And the question I ask my radiologist is, what do you need? What are you looking for? And some of the subtleties, I hope you'll stand up and ask that question when our more clinical colleagues, when our radiologists come up and talk about their protocols and say, what do you need to see? And it'll vary. It'll vary. Even in abdomens, it'll vary from time to time, from the indication for the exam in the first place, right? So I'm sorry I don't have a blanket answer for you, but I agree with your principles. If you're not looking for something subtle, if you're looking for fluid collection, you could probably knock down the MAS. If you're looking for a cancer patient to see if there's a new lesion that might have popped up somewhere, even something subtle, you may not want to reduce the MAS. You may need the thin slices and the higher MAS. Yeah, I wish I could give her better guidelines, but I hope we keep pushing back on our clinical colleagues to give us some guidance there. Tom.
Yeah, Tom Payne. And I want to mention one thing that your talks were very, very good. One comment, though, is that as you guys know, and most everybody knows, as we start to go from narrow beams to wider beams, the narrow beams in the middle, the rays coming to those channels are parallel. As we go further and further out, the rays are oblique. And a good little experiment is to go use your widest beam, look at the images formed from the detectors on the periphery, and compare them to the images formed from the detectors in the middle, and they're not the same. So, especially if you're doing an ACR accreditation, I did this once, and I went, shit, those look terrible. And then I went, oh, bang, bang, bang. Dumb physicists, use the middle.
All right, that's a great comment. Thank you, Tom.
Just following up on that comment, that's one of the reasons that the ACR accreditation dose testing got difficult for us, because as the beams got wider, the vendors recognized, don't make axial thin images in that wide beam because the edge ones look terrible. So we're going to disable that mode because we don't want to use it clinically. And then we go and try to do dose there, and we can't. So they've tried to keep clinical errors from happening, but it makes the physics testing.
Yeah.
Was Tom waiting for a response on that, or he just...
I sure hope not.
...want to share with us? Okay. Mike, I want to thank you and both gyms because you do an amazing job on this. And for people that haven't done this and they're looking at those calculations going, all right, feed per rotation per second, how many scan times, that is our world. We live doing that all the time. Is 10 seconds enough? 15 seconds? And the 16-slice examples you gave were great because I found a fork in the road in our practice when we went from 16 to 64. Because in the 64-slice equipment, you can pretty much stay in the thin collimation all the time and always have that thin option available. Except for maybe morbidly obese patients, we just live in the 64 by 0.6 or 0.625. And so it does make some of that decision-making easier. Not that I'm trying to sell 64-slice scanners, but we found that in our practice. We had a lot of the less of those forks-in-the-road trade-offs staring us in the face.
I appreciate that comment. And I'm not sure if we went too fast or too slow through that calculation. It'll be in the notes, and be more than willing to discuss at a break. But I think Cynthia's point is right. I did focus on the 16 because there is more of an issue of trade-offs there than the 64s. They really relaxed or giving you much more flexibility.
Yes, thanks very much. As a radiologist, I'm always trying to balance what are the clinical indications with what are the imaging requirements. And you showed very nicely the improvement in coronal reconstructions with using a narrower collimation detector configuration. Can you give me a sense, and this is probably going to be somewhat vendor specific, but what are the dose implications or penalties from moving from a thinner collimation to a wider collimation?
Okay. And let's make sure we're on the right terms now. We'll talk about collimation, beam collimation. That's the beam width at the time of acquisition. Okay?
That's correct. I'm not talking about the reconstructed image
Perfect.
slice thickness.
Perfect. Okay, good. So the difference is on the order of, let's say, let me think of an example. I can't quote the GE numbers off the top of my head, but the example I gave between the 16 by 0.75 and 16 1.5, maybe 10 or 15%. Okay? In a 64 slice, in the Siemens 64, between the 64 by 0.6 and the 24 by 1.2, on the order of 5 to 10%. These are not big differences. There are some scanners out there that, should I go back in history a little bit? No, I won't name names. There were some that was a big difference. If you went from 4 by 5 down to 4 by 1.25, that was on the order of 30 to 50% difference between those two. Just if you change nothing but the beam width, the collimation. Yeah. So these days it's a lot more. It's not as big, but there are some that are still out there that can be a big difference. And again, the CTDI vol will show it on the scanner. So if you can sit at the scanner and just change the collimation setting, and you notice what the displayed CTDI vol, if it's displayed, because it's not required to be displayed, but if it's displayed, you'll see it. Okay? Does that help?
Yes, thank you.
Okay.
Last one.
Okay, this is more of a comment and a plea to the rest of the speakers and to the audience. We need to be more careful with our terminology. I'm hearing it already today. Collimation, is it pinching of the beam? Are we talking beam width? Are we talking detector configuration? Because I heard Cynthia use it one way and Mike use it a different way. So let's just be very clear about our use of those words, or we'll all be totally confused before we leave here. The other one that I'm hearing a lot is slice. I have a pet peeve about slice. It gets used to mean all kinds of different things. If you mean image, say image. Otherwise, people are using it to mean beam width very often. So let's just, everybody try and be really anally precise about what we're saying.
I think that means no one's allowed to say slice anymore. That's where that. And apparently my slides have to be revised before they're posted. But okay. Should we let one?
Just one final comment. We're not quite there yet.
It's just the same direction. I think we should, as a radiologist, differentiate the scanning thickness and viewing thickness. And we as a radiologist,
say that again.
Scanning thickness, which is the physical number, and the viewing thickness. How thick is the slice we view? And when you look at the scanners that have 128 channels, 256, 320, you have the horrible choice between 0.5 millimeters and 1 millimeters primary scanning thickness. There's not much of a choice. But what you can choose is the viewing thickness, and that's what we're talking about.
Thank you for those comments.